So those were my declarations. The reason for selecting this topic is that there's been a great deal happening in bronchiectasis over the last 2 decades, despite the fact that it's a very old disease, originally described by Laennec, the inventor of the telescope. And well over 20 years ago, a colleague and I, in an editorial, wrote that it was entitled Bronchiectasis, a Neglected Cause of Respiratory Morbidity and Mortality. And then 20 years later, Paul Torzillo from Sydney in Australia, in another editorial, indicated that bronchiectasis was finally shaking off its orphan status. And I won't go through this slide in detail, but just to say that over the last few years, there have been tremendous developments in the area of bronchiectasis. We've had the production of updates or guidelines. We know about predictors of outcome and the ability to stratify for clinical trials. And a great deal of information has been developed in relation to what represents meaningful primary outcomes in studies of bronchiectasis. And finally, we're starting to get some good quality randomised clinical trials in this condition. And if any of you are interested, I would recommend the updated BTS guidelines if you want a reference on bronchiectasis. Although the diagnosis in this day and age of bronchiectasis depends on the demonstration of abnormally dilated airways on high-resolution CT scans of the chest, we've got to remember that bronchiectasis is a clinical syndrome, not a radiologic diagnosis. And so it is a combination of demonstration of those structural abnormalities along with symptoms, primarily cough and sputum. This slide basically summarises most of what I know about bronchiectasis. And the central part of this, the grey boxes, is the so-called vicious cycle of inflammation, infection and airway damage in bronchiectasis, originally described many decades ago by Professor Peter Kolbe from the Brompton, but for which there's been increasing evidence of support in recent years. Starting at the top, there's some sort of primary insult, and probably the best described primary insult is that of adenoviral infection in early childhood. And this leads to bronchial wall damage and destruction, and this is associated with impairment of ciliary function and abnormal airway dynamics, which influence the effectiveness of cough clearance. As a result of this, you have ineffective clearance of secretions, and then the development of chronic infection and associated inflammation, which in turn worsens the airway damage and destruction, and this cycle goes round and round. As in other airway conditions, people have applied this concept of treatable traits in bronchiectasis. And on the one hand, this really merely is a categorisation of what good physicians do in the management of bronchiectasis and have done for a number of years. But there are quite useful aspects in relation to looking at the categories of treatable traits. For example, the non-pulmonary category reminds us that in bronchiectasis, like in all chronic airways disease, we should always think about the influence of upper respiratory tract disease on symptoms and the role of esophageal reflux. In terms of etiology, this is actually quite important, and every patient diagnosed with bronchiectasis should undergo some investigations looking at a specific etiology for the conditions. Although it's relatively uncommon to find a specific etiology, the potential impact of finding such an etiology is actually enormous. So every patient diagnosed with bronchiectasis should have immunoglobulin levels. It's not necessary for them to have subclasses measured. They all should have tests for allergic bronchopulmonary aspergillosis, using whatever tests you use in your institution. Everyone should have a sweat chloride, looking for evidence of iron and water transport, which may indicate a diagnosis of cystic fibrosis. Remember that the patients who present in adulthood are going to have abnormal manifestations of cystic fibrosis and are also unlikely to have two mutations, two common mutations. So it's sweat chloride, not looking for mutations. We use nasal nitric oxide as a screening test, a moderately good screening test for primary ciliary dyskinesia. And you should always remember the association of bronchiectasis with certain connective tissue diseases, specifically rheumatoid arthritis and forms of inflammatory bowel disease. In recent years, we know a lot more about the lung microbiome. As with certain other inflammatory airways diseases, the microbiome in bronchiectasis is characterised by reduced biodiversity, a smaller number of bacterial and other species, and a predominance then of pathogenic bacteria, including Pseudomonas, Stenotrophomonas, and others. And we'll touch on this a little bit later, but Pseudomonas aeruginosa chronic infection is associated with the severity of the disease on HRCT scan, but also with a higher frequency and severity of poor outcomes, be it acute exacerbations, risk of death, progressive impairment of lung function. One of the things that's become clearer in recent years is, in fact, that this abnormal airway microbiome is stable over time, and that includes stability during acute exacerbations of the condition, which then calls into question the previous view that gram-negative bacteria were the primary cause of acute exacerbations of bronchiectasis. And there is increasing evidence of the importance of anaerobic bacteria, but also the potential role of viruses in exacerbations. In people having exacerbations, evidence of virus infection can be found in about 50% of patients. And the figure itself demonstrates what's happened to the exacerbation rates in bronchiectasis during COVID, during which time people were wearing masks and undertaking physical distances and thus reduce transmission of viral infections. And you can see the dramatic reduction in exacerbations, which would provide some evidence, perhaps, that viral infections are important in exacerbations. We also know a lot more about the mucus in bronchiectasis, because this is you can think of bronchiectasis as a muco-obstructive condition. There's more solid in the mucus, which is an indication of dehydration. There's abnormality of mucin secretion, in particular an increase in MUC5B, and there's also increased mucus osmotic pressure, reflecting hyperconcentration, particularly the sole component of airway secretions. And as you would expect, there's a higher DNA content, predominantly arising from lysed neutrophils. And of course, DNA, because it's long and sticky, contributes to the abnormal physical properties of the mucus. And these abnormalities of the mucus are correlated with bad outcomes, whether it be FEV1, the extent of bronchiectasis, or indices of airway inflammation. And these abnormalities lead to changes in the physical properties of the mucus, and the magnitude of these changes you would expect to contribute to the impairment of mucociliary clearance. Remember, there's not only the mucus, but there's also the infection and inflammation having a direct and adverse effect on ciliary function. Some recent interesting evidence was of abnormal ion and water transport in bronchiectasis, which is somewhat surprising. And this raises the possibility of a number of potential therapies, particularly the so-called mutation agnostic therapies being developed in cystic fibrosis, such as those affecting the sodium channels. And there is evidence that hypertonic saline, which we'll come to in a moment, can reduce this mucus concentration by a significant amount. So if we turn back to our diagram now, I'm going to just touch on a couple of the therapies in bronchiectasis that I hope might be of interest to you. And those therapies are shown in blue with the blue arrows. So first of all, nebulized hypertonic saline, which is of course a mainstay of therapy in the management of cystic fibrosis. And we know that that leads to an improvement in mucociliary clearance. Unfortunately, there are only two small randomized control trials, one which was negative and the other which was probably a stronger study design, demonstrated improvements in a number of clinically important measures. And perhaps most importantly, the British guidelines now recommend the use of nebulized hypertonic saline to augment the clearance of secretions in bronchiectasis. Has one other really important advantage, in that it is extremely cheap. Long-term macrolide therapy in bronchiectasis, well, we know on the basis of three large randomized double-blind placebo-controlled trials that long-term macrolide therapy reduces exacerbations in bronchiectasis by a clinically and statistically significant number. And although it reduces exacerbations, in the studies that have looked at it, it is, however, associated with the development of macrolide resistance. And so we need to step back a little bit in terms of the use of macrolide therapy in bronchiectasis. Remember that non-tuberculous mycobacterial infection represents an absolute contraindication to sole macrolide use. So you must always test the sputum for non-tuberculous mycobacterium before starting a patient on macrolides. And we're trying to balance the proven benefits against the possible clinical significance of the development of resistance. And it's not possible as a result of these trials to identify subgroups most likely to respond. And so most guidelines recommend the judicious use of macrolides, usually confined to patients who have ongoing severe symptoms of bronchopulmonary suppuration and or frequent exacerbations. I've already said that chronic Pseudomonas aeruginosa infection is associated with poor outcomes. And therefore, treatment of this, particularly with antibiotics delivered directly to the airways to reduce the bacterial burden and thus inflammation and thus reduce morbidity, that would seem to be a very logical way to go. However, the results of the studies, and they're summarised on this slide, are really disappointing. As you can see, very, very few of them showed statistically significant improvement on this plot. And there are a number of reasons for that. The difficulties in terms of deciding what the primary outcome might be, and the fact that bronchiectasis is a heterogeneous disease. It's just but two of those possibilities. But one trial that was positive, and it's from a long time ago, and it also has the benefit of being very cheap, and that is inhaled gentamicin. In a randomised controlled trial, inhaled gentamicin was associated with microbiological improvements, improvement in symptoms, and improvement in other factors that are often used as outcomes in studies of bronchiectasis in terms of exacerbation rate, health-related quality of life, and exercise capacity. All of the evidence suggests that as a respiratory physician, I tend to be wedded to lung function, and lung function is used as an outcome in asthma and COPD. It looks as though it's a very poor outcome measure in bronchiectasis. And therefore, probably the indications for inhaled antibiotics in patients who have chronic infection with Pseudomonas and who have a frequent exacerbation rate and or again, chronic symptoms of bronchopulmonary suppuration. Often when I give a talk on bronchiectasis, I get a question from the audience about surgery. What's the role of surgery in bronchiectasis? And there's no doubt that the pendulum has swung from 20, 30 years ago to quite a number of patients having surgery to quite few patients having surgery now. And the situation was summarised by John Crofton, the Edinburgh physician, way back in 1966. And he said it much, much more eloquently than I could ever do. And the bottom line is that there are some patients who seem to benefit from surgery. In some, that's obvious. In the majority, it's actually a lot more difficult. So what might be the role of surgery in bronchiectasis, and how might you go about determining whether a patient may benefit from surgery? Well, first of all, you ask the question, is the disease limited? Or by localised, I mean, is the disease overwhelmingly predominant in an area that could be reasonably surgically resected? Of course, you're only going to consider operation in patients who do not respond adequately to conventional medical therapy, either in terms of exacerbation rate or again in terms of volumes of cough and sputum. You might also be influenced by whether the patient has life-threatening complications, and that it would be most likely life-threatening hemoptysis. The patient needs to not only have usual therapy for bronchiectasis, but they need to undergo, if you like, prehabilitation. In other words, they need to be rehabbed before any consideration of surgical intervention, and you need to optimise their nutritional status. Somewhat challenging at times is to determine whether they have adequate cardiopulmonary reserve to tolerate therapy, and it would be best, as is the increasing case with management decisions these days, to be considered in a multidisciplinary meeting. And finally, is surgical resection the best option for this patient, or should you really be considering lung transplantation? So what I've tried to do is to give you a little bit more information about this vicious cycle of inflammation and infection in bronchiectasis, to update you on some recent knowledge in relation to that pathophysiologic process, and also to touch on, albeit briefly, on a few therapeutic options that you might wish to consider in this condition. So thank you very much.